We do recommend tier-based counseling, meaning you should talk to your patients about the most effective contraceptive first, and then ultimately in with your tier 3s with the barrier methods. We went through tier 1s, we talked some about tier 2s, we're still in our tier 2s, about 6 to 12% failure rate with our tier 2s. The transvaginal ring is a tier 2. We've got a couple of different versions of the transvaginal ring. They've got a couple of them have the ethylene estradiol and etorgestrol, and then the Annovera has a progesterone, and then the ethylene estradiol. So a couple of different components of that progesterone in them. They are made out of plastic, not latex, so they're okay to use for people that have a latex allergy. And the way that both of these are used is 3 weeks in, 1 week out to allow for that withdrawal bleeding. If we're going to start on day 1 of menses, you're going to start on day 1 of menses, no backup required, otherwise backup requirements for women. Meaning they need an additional form of contraception for that first week for use of the transvaginal ring. Typically for these patients, they may have an increase in that bleeding, increase in dysmenorrhea in the first few weeks, and they use it about 3 to 6 months, much lighter periods, much shorter duration, and then decrease in any associated abdominal cycle. Once it is taken out, there's pretty quick return to ovulation. So a couple within usually 2 to 4 weeks once taken out. So for the new ring and the LU ring, it's 3 weeks in, 1 week out, and they start a new ring when they go back. Once they have that 1 week out and they start over for their 3 weeks, it's a new ring that they keep in there. Okay? The Annovera, it's kind of worded a little bit confusing here. The Annovera is a reusable. So 3 weeks in, 1 week out, same ring goes back in. So it's reusable. The good thing about the Annovera is that it doesn't have to be refrigerated. It can be in hot, can be still efficacious in hot environments. So for deployment, it might be more beneficial when we have mill vans that are going to really hot and really cold environments. So it does not require refrigeration. Again, effective for up to a year. So in and out, 3 weeks in, 1 week out, back in for a year long. The rest of them, you're going to use a new ring when we start that next month. And for both the transvaginal ring, or for both kinds of transvaginal ring, it does not seem that weight affects the efficacy of these transvaginal rings. Let me make sure. Give me just a second. I need to see something here. I gotta make sure that this is the right. Yeah, this is good. Something, I made a change for a future presentation, and I want to make sure that I was done. Take it, kind of fold it, and then they put it up into the vagina. It doesn't have to be fitted or anything. And there are some transvaginal rings that are available over the counter now that patients can go purchase. They don't need to have a prescription for that. So what happens if a ring falls out? It's been less than 48 hours, insert the ring as soon as possible, no backup required. Greater than 48 hours, insert a new ring, and then backup is required for a week. There are some non-contraceptive benefits, especially to the combined hormonal contraceptives. And it comes from both an estrogen and the progesterone component. So increased bone density, we're going to see that from that estrogen component, at least for a period of time. So ultimately, we talk about postmenopausal patients, things change a little bit, but for our population that are going to be on these hormone contraceptives, we have an increase in bone density. We've got that change, or usually a decrease in menstrual irregularities. Remember, that's over time though. So oftentimes when they first start these medications, they'll have some irregularities, maybe some increase in bleeding, but over those first few months, that will change and decrease the irregularities, which is why we use these medications for women that have irregular menstrual cycles. Dysmenorrhea, if they're having dysmenorrhea from something like endometriosis, Okay, it helps improve the dysmenorrhea by reducing the prostaglandins and associations with NSAIDs. And then reduce risk of endometrial and ovarian cancer. Any idea why? So most of these, their primary mechanism is by affecting ovulation, right? The less we ovulate, the less we're breaking the outside lining of the ovary for that. And then for the endometrium, it's keeping that endometrium thin, right? It's keeping that endometrium thin so we don't have those secretory secretions and thickening of the endometrium, so that ultimately will help to decrease both endometrial and ovarian cancer. And then we talked about this, when we talked about PCOS. Combined oral contraceptives are really good to help prevention of development of hirsutism. It doesn't help if someone already has hair there. We have to do some laser treatment for that, but it helps to prevent the development of new hair growth. And then improved acne, we talked about that as well. So a lot of non-contraceptive benefits. There are, unfortunately, some complications as well. These are mainly due to our estrogen component. We know an increased risk of VTEs, increased risk of stroke, okay? Increased risk of liver disease and cholelithiasis as well. And then a lot of times we'll actually use combined oral contraceptives to help stabilize a patient's mood. Sometimes it makes it worse. So we just have to see what kind of the amount of estrogen and progesterone that specific contraceptive has in it, and you may have to change the amount of estrogen and progesterone. There are some absolute contraindications. So instead of memorizing this, what would we do? We look at the USMEC, right? At the checklist. USMEC, we're going to do 1s and 2s. We're going to avoid 3s and 4s. So these are mainly your 4s. Someone smokes. They've been 15 cigarettes a day, and they're over 35 years old. Combined hormonal contraceptives aren't going to be good because it has that estrogen component. That's going to increase the risk of VTE, increase the risk of stroke. So again, I wouldn't spend time memorizing this because on the exam you will get the USMEC, the colored pages, so you'll be able to figure out if I say this patient has these, this medical history, which contraceptive would be. Be careful of wording. Careful wording. If I say they have these conditions, which one would be most effective, and you choose a tier 1 when there's a choose a tier 2 and there's a tier 1 answer, you'll get it wrong. Okay, because we're talking about most effective. So make sure you pay attention to what the wording is asking. There's going to be a couple of different options typically on there, but you want to choose the most effective administration. Progesterone-only pills are also tier 2s. They're also known as the mini pill. They come in a couple of different varieties of progestin, and that's all they have in them is progesterone. It's going to work like our other progestins by thickening that cervical mucus, which impairs sperm motility, inhibits implantation, and then it can affect ovulation as well, but it's not the primary mechanism of action for this. Except for if we look at drospirenone does, that's one of the newer ones that does affect ovulation. This is only available, at least in the United States, in a 28-day pack. There's no week off. You just take it 4 weeks in a row. No placebo pills are used. Oftentimes, we use this in patients that are breastfeeding, that want contraception when using breastfeeding. Okay, those that have restrictions because of the estrogen component that we're missing, they come on hormonal contraceptives. We can use it with the POPs, the progesterone-only pills. Once if they have cardiovascular disease, history of stroke or blood clots, and this would be a good medication for them. And even migraine headaches, because typically migraine with auras, you'll notice it's a 3 on your USMEC, so we don't typically use combined oral contraceptives in those patients. Contraindications, like we're talking about with all of our contraceptives, is if they're pregnant, we don't want to give them contraceptives. Now, truth be told, if you read the literature, I mean, there are probably a lot of patients that have gotten a dose or 2 birth control pills while they're pregnant, okay, or contraceptives while they're pregnant. Not typically with an IUD, but there hasn't been any specific recorded detrimental effects to mom or the baby if they happen to get this. It's just poor form, right? We want to make sure we ask the questions, we document that we're certain, reasonably certain that this patient is not pregnant by using the CDC guidelines or a urinate CG. Okay, so, but we want to try to avoid giving these patients contraceptives if they're pregnant. If they have a history of breast cancer, liver disease, all the things we already talked about that are associated with progesterones. So we start this if it's the norethindrone or the norgestrel. Okay, if you start within the first 5 days of the menstrual period, okay, there's no contraceptive needed. If it's greater than 5 days, then we need additional contraceptives for 2 days. Okay. If you're on the instructed with something with the drospirenone, if it started on the first day of the menstrual cycle, no additional contraceptive needed. If it's more than the first day, then we need additional contraceptives for 7 days afterwards. What happens if they miss the dose? Okay, so it depends again if you're giving them drospirenone or if you're going to give them norethindrone or the norgestrel. So if they have the norethindrone or the norgestrel and if they miss a pill, now we talk about missing a pill, we're talking about not a day, we're talking about hours. So the problem, the biggest issue that we have with progesterone-only pills is they pretty much have to be taken at the same time every day. If someone were to take it at 3 p.m. today, if they don't take it by 6 p.m. tomorrow, that's considered a missed dose. Okay? And if they have a missed dose, then you want to go ahead and have them take that pill as soon as possible, and then they're going to need backup contraception. For the drospirenone, there's a little bit more leeway there. You can have that 48 hours for the drospirenone. So depending on which progesterone-only pill you give them will depend on what their backup or their additional contraceptive is going to be if they miss that dose within that short window. Okay, our tier 3 methods are our barrier methods. We talk about male condom, female condom. Now, ideally, you want to talk to your patients that if they're using these, do not use the male and female condom at the same time. Why? Friction. So you've got, latex on latex, right? So you're more likely to slip, you're more likely for breakage of the condom. So either one or the other. Diaphragm, we don't really typically use these very much anymore. They do require fitting, and so unless you're taught how to fit them, if someone specifically wants to use it, you'll have to send them to OBGYN to get fitted for the diaphragm. It can be inserted up to 6 hours before intercourse. It must remain in place for 6 hours after intercourse to have the full effectiveness. If it does not have spermicide built in, and they can use additional spermicide with it, and that increases the efficacy of this. Slight increase of UTIs. Any reason why? Because it's being held up by the urethra and intravaginally for 6 hours. And associated with that spermicide as well, kind of just hold the bacteria there, and that's why they have that increase. Failure rate, 6%, we say with perfect use, meaning I'm putting it in 6 hours before, I'm leaving it in 6 hours afterwards. Then we have 6%, 12% for most people. Most people don't leave it in for that 6 hours. So again, it's about educating your patients if they're going to use this. There's fertility awareness methods, things like cervical secretions. Cervical secretions, they kind of read several paragraphs on how to identify the thickening of their cervical secretions and how the thickening of their cervical secretions are going to change if they're ovulating versus non-ovulating time period. Basal body temperature, every morning before they get up, they take their temperature, they document it. At the time period where their temperature goes up by a degree or two, that's when they're ovulating, or they're going to be ovulating within a couple of days after that. We've got the calendar method as well. So those are all fertility awareness methods. If that is something that you feel is important to talk to your patients about, then there's a lot of literature out there on those methods. I would brush up on that because you want to be prepared to answer your patients' questions if they're going to talk to you about the fertility methods. Of course, these do take education not only on the patient's part, but on the provider's part. And if you don't want to memorize the stuff, that's great. have a printout for the patients. Hey, I'm glad you asked about that. Here's your printout. Why don't you take this home and read it, or you can read it here and let me know if you have any questions, and I can answer those, or if you want to choose some other form of contraceptive. Once they figure out the amount of time and persistence it may take to learn these options, they may choose a different option. Motivation from both partners to be able to do this as well. A 24% failure rate in that year. So 2,500 a year will typically get pregnant by using the fertility avoidance methods. And usually it's just because of lack of education in the doctors. We got spermicides. Usually those have minoxidil 9 in them or octanol 9. And so they have are effective for about an hour. So you got to use them, and then within that hour, otherwise you will have a significant decrease in effectiveness. They want to tell the patient to avoid any sort of intravaginal cleansing or douching for at least 6 hours after intercourse. So they're effective for about an hour, and then 6 hours after intercourse, we want to make sure that spermicide kind of stays in there to reduce the motility of the sperm. We have no STD protection that's associated with this, or STI protection. Really, the only thing we did that from is we get a little bit from the diaphragm and then from our condom. Potential increased risk actually for HIV and STI, and that's because that spermicide is being held in the vagina, and so allows time for the bacteria to stay in the vagina and go out around the cervix. 24% failure rate associated with this as well. We've got the sponge, and this is available over the counter, and it has the non-oxidil 9 in it. Can be inserted for up to 24 hours prior to intercourse, and it provides contraceptive benefit, whether it's one coital episode or multiple coital episodes within that 24-hour period. Again, must remain in place for at least 6 hours after intercourse to provide full efficacy. We need to know about the emergency contraception. And of course, we all know that there's differing laws in different states on emergency contraception, so depending on where you're going to be working, but you need to understand that there are some states where we can still use emergency contraception. So, do you know what literature you read? Some literature will tell you that some of these have to be used within 3 days. Other literature says within 5 days. The majority of literature now, in the last 2 years that has come out, said, look, 3 days is ideal, but we can get pretty good efficacy up to 5 days for most of these. The copper IUD is still going to be the most effective emergency contraception, most effective. The problem you'll run into is if you are not credentialed to insert an IUD, it doesn't have any benefit for you. You have to find someone then to insert the IUD. So that means put a consult in to see OBGYN. It's not likely they're going to see. Don't send it to the emergency department, because emergency department providers are not credentialed to put in IUDs either. So most of the time we're not going to be able to use that. So then we have contraceptive pills that we can use for emergency. Ulipristal is going to be the most effective oral contraceptive pill. This is one pill, one dose regimen, but it does require a prescription for you to do that. It can be taken up to 5 days after unprotected intercourse. Less effective, we have the levonorgestrel or the Plan B. That is over the counter. They need to go to the pharmacist to get that, and they take a 1.5 milligram dose, one dose, or they can take 2 doses. And then we have something called the USP regimen, and that is combined oral contraceptive, but it's taken a little bit different. So you have one dose of 100, one that has 100 micrograms of ethylene estradiol plus that levonorgestrel in it, and then you got a second dose followed 12 hours later. So that's a 2-dose regimen. Now, once we provide emergency contraceptive, we want to tell the patient this is not, we don't just do this and we don't think about contraception afterward. We want to make sure that they have contraception after the emergency contraception. So if we use the IUD, the copper IUD, or the Plan B, we can start any contraceptives. We can do, keep the IUD in place. We can do combined hormonals. You can do the implant, you can do the Depo, any other combined contraceptives that we talked about. Okay, still needs 7 days backup once we start this. If ulipristal was used, if you use ulipristal, you want to wait at least 5 days before you're going to use hormonal contraceptives. So that means any of the contraceptives we talked about, right? So progesterone is a hormone, and the combined hormonal contraceptive is all hormones. And that's because it decreases the effectiveness of the ulipristal. So you want to avoid the hormonal contraceptives. You can just do a copper IUD, can be placed right after ulipristal, but not any of the hormonal contraceptives. 7-day backup is recommended. Postpartum contraceptive. So postpartum contraceptive, we think of breastfeeding as protective for up to 6 months. I saw a patient last week in the emergency department. She was 3 months postpartum, breastfeeding full time, and man, if she wasn't pregnant. And she said, this happened to me last time too. I went, well, you gotta take a note about this next time. Think about it. So we think about it in the majority of cases, right? Not everybody falls into those lines. But overall, we think about breastfeeding as protected for those patients that know they've gotten pregnant before, despite breastfeeding full time. We talked about immediate postpartum contraception. Most of the time, OBGYN is going to wait for 6 weeks postpartum to start anything. Most of the time. They can, however, they could use the IUD immediately postpartum. You could use the implant. You could use the injectables, use progesterone-only pills. They can do that immediately the day after delivery. But again, most of the time they're going to wait till they come back for their 6 weeks postpartum check, and then they say, okay, what do we want? What do you guys want to use for postpartum contraception? Part of the reason that is because remember that the cervix is dilated from having the baby. And so, if it's a vaginal delivery. And if you put an IUD in a cervix that's already a little bit dilated, you have a much higher expulsion rate in those patients. For FDA, or DMPA, which is the depo-hydroxyprogesterone acetate, that is the Depo-Provera injection, the FDA recommends that we wait till that 6 weeks postpartum visit before starting that. Now, at 6 weeks, we can now put these patients on combined hormonal contraceptives. Why don't we want to do it before 6 weeks? Estrogen. And we don't want to increase estrogen. That first 6 weeks postpartum, these patients are at very high risk, the highest risk that they would be at for PEs and DVTs. So for venous fungoilism, is that first 6 weeks postpartum. So we don't want to increase that risk by providing a combined hormonal contraceptive that has estrogen in it. In addition, estrogen can decrease milk production. So for patients that want to breastfeed, we don't want to hinder that. We're beyond 6 weeks, you can use any contraceptive. If someone had a spontaneous miscarriage, or if they had an elective abortion, they can ovulate shortly after having that miscarriage or after having elective abortion, so usually within a couple of weeks. So we want to make sure we talk to these patients about contraceptive, and they can use any contraceptive. Okay? The same thing we can think about, though, if we think about a miscarriage or abortion, that cervix is going to dilate a little bit. So these patients, if they choose to have an IUD that's placed, there's going to be a higher expulsion rate in those patients in the first few weeks. So that's something they choose. Talk to them about backup contraceptives, and usually we'll think about inserting the IUD at about 6 weeks post miscarriage or abortion. So we've got to remember the US NEC, we've got to remember the US SPR as well, that companion document that talks to us about when doses of contraceptives are missed and what do we do about those. When the contraceptives can be started, how far, what is the backup plan for contraceptives for these patients. Know that 1s and 2s, we're good with that. 3s and 4s, we want to avoid. 3s, if the benefit outweighs the risk, and 4s are no-goes for sure. All right, that is it for contraceptives. Let's go on to our abnormal uterine bleeding. Anybody wine drinker? Probably won't be after this picture. We got our TLOs and our ELOs. Let's do a little review. 27-year-old comes in, chronic pelvic pain, has endometriosis, says her pain is worse during menses. She is not planning on conceiving in the near future. Which contraceptive might be best for this patient? So I'll tell you, seasoning is that extended cycle or continuous. The ortho, that's the patch, right? We've got the next put on, that's the subdermal implant, copper IUD, or the progesterone needle. Anybody with going with A? Probably, right? Because if we do a continuous or an extended cycle, what are they having less of? Periods. They're having less bleeding, right? And so if they're saying, hey, every time I have a menstrual cycle, I have severe dysmenorrhea, hey, there's no medical reason for you to have a menstrual cycle. Let's just have you not have a menstrual cycle. And we can do that by putting them on medication. So orthorefal patch, it's less effective, okay, for that continuous use. If you wanted to put a patch after patch after patch, it's not going to be as effective. And we have the implant. It can ultimately reduce the period frequency, the menstrual period frequency, but not going to be as beneficial as that extended cycle. And then progesterone only, they don't really provide a tremendous amount. They can use symptom relief dysmenorrhea, but they're not for long term. So we've got our seasoning. A 19-year-old female comes in, concerned about acne. Has not improved with over-the-counter treatments. She's interested in maybe a contraceptive that might help. Which contraceptive do we think will help with acne? Yes, okay, because it has that drospirenone. And drospirenone, remember, is which progesterone? A novel progesterone generation. So they're the newer generation with that drospirenone progesterone. So that's going to increase, has less anti-androgenetic, or has more anti-androgenetic effect. All right. When we think about abnormal bleeding, we've got to remember what normal bleeding is. So we got to know what normal bleeding means first. So normal bleeding should be cyclic, especially in patients that are reproductive age. Okay, it's predictable, pretty much, most patients, reproductive age will say, yep, my period is every 28 days, every 30 days, they kind of know when it's going to happen. And relatively consistent duration and the amount of bleeding. Most people know how many sanitary products they're going to use during their time, their menstrual time, bleeding phase. Typically, it's going to occur every 21 to 35 days, lasts from 3 to 7 days, and the total blood loss is anywhere from 20 to 60 ml, which is really insane because for those of us that have had menstrual cycles, we always think it's way more than 20 ml. You're talking about 2 syringes, 2 10 ml syringes of blood, up to 6 ml syringes of blood. And that's nothing, right? Doesn't seem like nothing, but when it's ongoing, you're like, it seems like a tremendous amount. So then when we have abnormal bleeding, it's no longer, it's not that normal frequency. It's not occurring at regular times. It's heavier sometimes. It's lighter sometimes. It's occurring more often than expected. It's occurring randomly. Maybe it's later than what I expect. It's really, really common, affecting about 1/3 of women. Okay? And we're going to see it more often at those extremes of age because the HPO axis is immature, and the early onset of puberty, and then as we go towards menopause, when everything is giving out, right? The menstrual cycle gives out too, which is yay for that, but then you have menopause. So if you, depending on your reading, you guys from midnight to 4, your free time reading, you may see different terminology. So older terminology I have here, and I have the newer terminology. So we used to be called dysfunctional uterine bleeding, but nobody likes to be called dysfunctional, so they changed it to abnormal uterine bleeding. Oligomenorrhea is now light menstrual cycle. Menorrhagia, heavy menstrual bleeding. and metrorrhagia as intermenstrual bleeding. And I'll be honest with you, I'm super happy that they changed these because I could never remember the difference between menorrhagia and metrorrhagia. Because there's nothing in those words that give you a clue that one's intermenstrual and one's heavy. So now we just say it's heavy menstrual bleeding, HMB. It's intermenstrual bleeding, IMB. And that's how you can document on your chart as well. And this is how we define menstrual cycles kind of three-dimensionally or dimensionally. We mentioned that frequency is going to be that 21 to 35 days. Okay, so if it happens before 21 days, we would say that is frequent menstrual bleeding. If it happens greater than 35 days in between each bleeding phase, that's infrequent menstrual bleeding. Regularity, we think about amenorrhea, greater than 3 months, no menstrual bleeding in a person that normally has regular menstrual bleeding. That definition changes if they have irregular menstrual bleeding to 6 months of amenorrhea, okay? Or if they have more than 20 days variation in their cycle days. This month I started on the first day of the month, and then now this next month, that was the last day of the month, so there's more than 20 days from that first day from the onset of the menstrual cycle. We call it irregular menstrual bleeding. Think about duration. So duration, prolonged is going to be greater than 8 days, and shortened is going to be less than 2 days. So you would say, a person comes in and say, yeah, my menstrual cycles are lasting, my menstrual periods are lasting about 10 to 12 days. You would say, a patient has evidence, is reporting prolonged menstrual bleeding of 12 days. And then volume. Greater than 80 cc's, we think about heavy menstrual bleeding, okay, or HMB. Less than 5 cc's, which is essentially a regular tampon or pad, that is light menstrual bleeding. And then intermenstrual bleeding is, I had a menstrual cycle, and then a week later I had one again, and I'm bleeding in between my cycles. When someone comes in and they say, I'm bleeding really, really bad, it's really hard for us to quantify that in our mind because it's hard for the patients to quantify that. So if you've ever, we have patients, males will come in and say, I peed and there was blood in the toilet. How much blood? I don't know, it was completely full. Do an experiment. Take 1 drop of red dye and put it in the toilet. The whole toilet looks like it's full of blood with 1 drop. So it's hard for patients to quantify because they just know, I don't know, I looked in the toilet and it was full of blood. Now, so we want to ask them specific questions. How many sanitary products are you using per hour, per day, per cycle? Okay. Are you passing any clots? And if so, what are the size of those clots? Are they dime size? Are they quarter size? Are they 50-cent size? You want to know that. How often are you passing the clots? Is it every single day? And is it multiple times a day? Have you ever been told that you have an anemia, that you're anemic based on your blood work? Okay? And if so, we also want to ask them about how long are these menstrual cycles lasting? So there's questions that we can ask them that lead us in a direction of, it seems like this may be a normal amount of bleeding, or it seems like this may be an excessive amount of bleeding. Your other option is doing something called tampon math. And really, nobody wants to do tampon math. I mean, are we going to have our patients come in and say, bring all of your sanitary products in so we can figure out what's going on? No, don't do that. They would think that's weird. I also think that's weird. So we don't do that. We don't do tampon math. Okay? But when you look at this, again, a normal tampon, a normal pad holds 5 cc's of blood, of fluid. Okay? If you have an absorbent, 10 cc's of blood or of fluid. That's how you can quantify. How many products are you using? Is it normal, is it regular, or is it super absorbent? Okay? And how many you're going through. And then in your mind, you can kind of do some calculations on how much bleeding they are having. Because it's going to be hard for your patients to quantify that to you. So we've got to ask those other questions. When we think about abnormal uterine bleeding, now we think about this as a diagnosis of exclusion. So if someone comes in and they're having irregular menstrual cycles because they have polycystic ovary syndrome, well, the diagnosis isn't abnormal uterine bleeding. The diagnosis is polycystic ovary syndrome, and this is a symptom of their underlying disease. Okay? So we want to think about this as a diagnosis of exclusion. We're trying to identify a reason for them to have this abnormal bleeding. According to the International Federation of Obstetrics and Gynecology, okay, they created this fun acronym that we can use to help us kind of separate the different, most common causes of abnormal uterine bleeding. They have PALM and they have COIN. PALM and COIN. So PALM are going to talk to us about our structural causes of abnormal bleeding, and then COIN is going to talk to us about non-structural causes of abnormal bleeding. And this abnormal bleeding are really focusing on patients' reproductive age. If someone comes in and they're postmenopausal and they're having bleeding postmenopausal, we call that postmenopausal bleeding. And there's a whole nother version of that. When we talk about postmenopausal bleeding, that's super concerning because this patient don't have a lot of circulating estrogen. Okay? And most of these things that we think about, especially the structural abnormalities, those are estrogen dependent abnormalities. So if they're having postmenopausal bleeding, those patients are more have to have something serious going on as opposed to that. So 25% of patients are going to have some sort of structural abnormality. Maybe a polyp, adenomyosis, leiomyoma, or could be some sort of malignancy or hyperplasia that's associated with endometrium. So let's talk about those. We got 75% are going to be non-structural abnormalities. Maybe they have an underlying coagulation disorder. Maybe it's ovulatory dysfunction. They could have endometriosis or endometrial hyperplasia as the cause. Iatrogenic, meaning we did it to them, okay, or they're taking a medication. We talked about, even birth control pills or contraceptives can cause some abnormal bleeding. Okay? So, and then not yet classified, we think about things like infections, STIs, cervicitis, something like that. In our Williams OBGYN book, these are the tables, and this is where we get this information from. So that book is about 5 years old, and that's when these classifications changed about 5 years ago, so we can use that tool. Knowing the age of your patient is going to help with your differentials. Okay? And it's going to help you identify if you think this is a more likely to be a structural cause or more likely to be a non-structural cause. So if someone is bleeding, having come in and they're very, very young, so 4, 6 weeks, 8 weeks old, a couple months old, and mom is bringing that patient in for vaginal bleeding, a lot of the time that's an estrogen withdrawal because mom's estrogen is still in the baby when they're born. And as that estrogen level decreases in the baby, they can have some bleeding, which is completely normal. Okay? Someone is premarital, okay, and they're having this bleeding. That would be unusual, right? We think about maybe they do have an underlying bleeding disorder, maybe foreign body, maybe trauma. So you want to ask those difficult questions. Somewhere between 13 or 14 and 49, those patients have a pretty mature HPO excess. So if they're coming in with irregularities, now we're going to start using that PALM and that COIN to help us figure out what the cause is. Is this, are they on a hormonal contraceptive that's causing this? Do they have some sort of structural abnormality? Okay. Those patients that are around that time of menopause, we expect a little bit of anovulatory cycles to be mixed in there, so it's not unusual for these patients to have irregular menstrual cycle. Over the age of 52 or so, 52 and a half is when we think about most patients have gone through menopause. If they're bleeding beyond that, again, we think more, is there something wrong, something is thickening the endometrial lining that's causing this. Maybe it's atrophic vaginitis, and so we can treat those patients. But you want to think about reproductive, okay, postmenopausal, and then pre-pubertal reasons kind of separate out that. If you have a 44-year-old patient that came in, she's P3, okay, 2 years of irregular bleeding. She said, I'm bleeding 14 days out of the month. And sometimes I have just like the spotting, And sometimes I have heavier bleeding that I actually have to use a pad and change those pads out. Okay, sometimes I have bleeding through the pads that I'm using. She said, you know, this really sucks. I'm tired of this. Why am I having all of this? And she wants to know, can you fix her period? She's always tired, always fatigued. So that gives us our frequency, gives us our regularity. When we're talking to our this patient, is the duration. She's been 14 out of 30 days. Okay, she varies in amount. So we want to ask those questions when we're asking our patients about when they come with this abnormal bleeding. Think about those dimensional words: frequency, regularity, duration, volume, or amount. We document that on the patient's chart so we can answer those questions. Clinically, we would say she doesn't necessarily only heavy menstrual bleeding or intermenstrual bleeding or light bleeding. She has abnormal because she runs the gamut. She complains about all of it. And she's 44, and because she's still having, could she be in menopause? Could she be in early menopause? She could. Okay, she could. We haven't talked about menopause yet, but usually we think about menopause again between 47 and 52 and a half or so. But people can go into menopause a little bit early, so it's possible. Maybe she needs some labs to help us figure that out. But right now, we're going to say she has abnormal uterine bleeding because it is a diagnosis of exclusion. Now it's our job to figure out why she's having this abnormal uterine bleeding. What lab test do we need to obtain first? Yeah, we gotta have an HCG. Whether it be a urine HCG or a data HCG, we gotta have an HCG on this patient. These other labs may prove important at some point, but we definitely want to make sure we have an HCG in our labs. All right, so our structural causes. We have polyps, we have our adenomyosis, leiomyoma, also called fibroids, and then we have malignancy or endometrial hyperplasia. So we're going to talk about those first. Remember, these are really estrogen-sensitive components that are causing these structural causes, and that's what we see them if we see them in reproductive age patients. If we see the development of new lesions in a postmenopausal period, it doesn't always mean it's cancerous, but certainly it's going to be higher on our list in those postmenopausal patients if they don't have a lot of circulating estrogen. So our endometrial polyps that are AUBP, it's the P in our palm. And these are just hyperplastic growths. The majority of the time they're non-cancerous, but they do have vessels that are associated with them, which is what causes that bleeding. Up to 25% of patients can have polyps, and we can see that at any age, but we usually see them in the late 40s or 50s time period. It's one of the most common causes of intermenstrual bleeding. Okay? Most common cause of intermenstrual bleeding is this. How do we diagnose this? Do we think we do a pap smear or cervical cytology to diagnose it? Probably not, because it's in the uterus. It's in the uterus, right? So usually a transabdominal or transvaginal ultrasound, we can identify it, or we can use something called a sonar hysterography, also known as a saline infusion scan. And what they'll do is they'll take fluid and they'll infuse it into the uterus, and then they'll do an ultrasound when that fluid is in the uterus to try to highlight any sort of structural abnormalities inside the uterus. Treatment is they can typically just take it out. They'll go in there and cut it off or freeze it off, and then they'll burn that area and less likely to do that. With cervical cytology or pap smear, not useful because it's inside the uterus. Okay. So on this picture, let me orient you real quick. This is the uterus. It's outside here. This kind of hyperoculpary here. This is that's the endometrial stripe, the endometrial thickness. Okay, so normally we think about endometrial thickness for reproductive age females. It can change from day to day, depending on where they're at in the menstrual cycle, because of the amount of estrogen they have early on in the menstrual cycle versus later in the menstrual cycle. Okay, but usually 4 to 6 millimeters. Postmenopausal should be less than 4 millimeters. What they have done, this is that sonar hysterography or that saline infusion scan. They took fluid, it came through the cervical os here with a, what's it called, like a pipette, and they put fluid into the uterus. So that uterus comes around and the endometrial lining essentially meets at the middle of the uterus. So they go in through the external os, into the internal os, and they put fluid into the uterus, not into the myometrium, but into the uterus. Okay? And then what they highlighted is, look at this big mass right here. It's a mass. Does anybody see that over here? I mean, retrospectively, you may be like, oh yeah, I completely see that. But you didn't. Probably most people didn't. I wouldn't have seen it. So that's the benefit of infusing saline or fluid into the uterus. If they think that the person is having bleeding, the ultrasound, they don't see anything on the ultrasound, then the radiology folks can do this kind of procedure in the radiology suite to try to highlight any structural abnormality that they have not been able to see or not able to see on the ultrasound. All right, our A of our poem for structural abnormality, A is adenomyosis. So adenomyosis is really interesting because it's somehow the endometrial cells have made their way into the myometrium. So those endometrial cells, which are normally just a lining of the uterus, they have kind of crept through the muscle tissue and they are stuck inside the muscle of the uterus. Right? And because those are endometrial cells, every month that the patient has their menstrual cycle, they're going to try to slough off. They're going to proliferate and they're going to secrete, and then ultimately they're trying to slough off. But they don't because they're inside the myometrium. Do you think that would be painful or not so painful? Super painful for these patients. Super painful. And how they may present is progressive dysmenorrhea. And then on exam, I've got a couple pictures here. On exam, those endometrial cells are making that uterus kind of abnormal feeling. So the fundus, if it's on the fundal area, the uterus is globally bigger. You're like, hey, wait, I normally can't feel a uterus, but I can feel this one pretty good. And it feels a little lumpy. Because depending on where those endometrial the adenomyosis is at. Certainly, the adenomyosis is on the lateral aspects. You're probably not going to see that unless it's enlarging the muscle so much that the entire uterus is globally enlarged. And we say typically for these patients, it can be up to a 12, as if they have a baby that was 12 weeks. So a baby that's 12 weeks, we would have the fundus of the uterus just above the pubic symphysis. So normally, when you push down, you're going to push down around the pubic symphysis area. You won't feel much. But now we're going to push above there. We can actually feel the fundus. That would be concerning the patient that's coming in with dysmenorrhea, so painful menstrual cycles, and an abnormal uterine bleeding. Again, they're not really sure how those cells are getting there. Okay? Are they just kind of transudate, where they're kind of just moving through to the muscle? Are they coming around and coming through the fallopian tubes and getting into the muscle? They're not really sure. More commonly, we see this in a little bit older population, 40 to 50, but I've seen lots of women even in their mid-30s that have this. The problem is they're not diagnosed until late 30s to 40s because patients like, the providers think that it's just a normal part of the menstrual cycle for these patients at this moment. So you have to have a high index of suspicion, which is why it's really important. Oh, we got to take a break. Which is why it's really important to have your differential. All right, let's take a break. Patients can be asymptomatic. And that's usually very early on in the disease. Once they have a decent amount of endometrial stromal glands or in the myometrium, they're not going to be symptomatic. They're going to have pretty significant dysmenorrhea to the point where sometimes they miss days of work they can barely get out of bed because of the discomfort. And that oftentimes will start a couple days before the menstrual cycle and get better within a couple of days of starting the menstrual cycle. Otherwise, abnormal uterine bleeding, dyspareunia, dysmenorrhea, that may be your signs and symptoms. How do we evaluate that? Typically transvaginal ultrasound, but they can do transabdominal ultrasound. So the way the ultrasound machines have just taken off the last few years, and how much better and clearer the image is, they've kind of changed where we used to only do transvaginal, but they can do a lot of these transabdominal now. So the recommendation when you order it, I would recommend ordering a transvaginal ultrasound. The patient complaining of several months or whatever, of dysmenorrhea and abdominal bleeding, please evaluate for potential abnormality. And then oftentimes the radiologist wants to know, and you guys should order some radiology, the radiologist wants to know what you're looking for. Right? So give them a couple of your differentials that you're looking for on there. And then of course if they see anything else, they can identify it, but hey, what are you looking for on this patient? So they can really clue into that. So we're going to do that, and that's going to be our initial study of choice. Endometrial biopsy. So if we go into the internal lattice, and they do a biopsy of the endometrium, why do we say that's frequently non-diagnostic? Yeah, we're not going into the muscle, we're going into the endometrium, so you're not likely to identify anything on that biopsy. So that's not going to be your diagnostic tool of choice. MRI. Remember, pelvic MRI, if that's an answer, I wouldn't choose it. And I wouldn't choose it on the board either because they're going to try to get you to choose it. It's not an initial diagnostic study. Now, the pelvic MRI is actually really good at diagnosing adenomyosis. But ultrasound is pretty darn good easy as well, and you can get it done a lot quicker. So MRI, anybody had an MRI recently? Usually when you call an MRI, it's going to be about 6 to 8 to 12 weeks out. So a couple of months before you can get your MRI. Because MRIs take a long time to get done, an hour or so per MRI. So go to ultrasound on these patients. If you still have a high index of suspicion, that's not showing you anything, you're still having these complaints, then ultimately it may be a pelvic MRI. How do we treat patients if we have a diagnosis of adenomyosis? Contraceptives are typically considered our first line. We can do levonorgestrel IUD, and that's going to become a theme as we talk about continue to talk about abnormal bleeding. Levonorgestrel IUD, OBGYN folks love it for abnormal uterine bleeding. They love it for dysmenorrhea as well. Combined oral contraceptives can work. GnRH agonists may work, but should not be your initial treatment of choice because there's a lot of side effects. It pushes patients into that false menopause, so the patients are not only going to be having abnormal bleeding, but then they're going to be having hot flashes, mood swings, and so that's not going to help them. Right? So usually we start with that progesterone IUD or combined oral contraceptives. And then ultimately, if they fail medical management, and they may end up in a hysterectomy. Actually, a good friend of mine had this for many years, and she ultimately, against what she wanted to, she didn't have to do hysterectomy. She said, I just can't even function. I'll go for a week out of the month, I can't get out of bed for a week. So keep this in mind as your differential for dysmenorrhea and abnormality. Okay, our AUBL, our leiomyomas, that is our L in our palm for our structural abnormalities. And this is going to be the most common cause of abnormal uterine bleeding. We can see this in like 80% of women. Again, these are very estrogen-dependent tumors that develop. They grow over a slow period, pretty slow growing over a period of time. And that's why oftentimes patients will have these for several months before they'll come in complaining of increasing pain or increasing bleeding. On exam, instead of that kind of global enlargement of the uterus that we feel, these are more discrete. Right? It's almost like you just take a marble and you put it into a myometrium and you put it into the fundus. So it's kind of more of a discrete, kind of rubbery mass that we might feel in these patients. We have a couple different types that we can see. You can see here on the picture we have subserosal. Now someone has a subserosal, it's on the outside of the myometrium, you may be able to feel that, especially if it's in the fungus. If they have a subserosal on the side, you probably won't be able to feel that. If they have submucosal, probably not going to be able to feel it. Those are the ones that primarily cause a significant amount of bleeding that's associated with that. And then if they're intramural, meaning they're in the myometrium, those are the ones that are going to cause a significant amount of pain. And patients can have a mix of all of these. They can have some that's subserosal, they can have some mucosal. And we have some small ones down here that are near the cervix. If those get really large, okay, these patients may come in with amenorrhea, right? Because it can prevent the pathway for the blood to leak. Okay, so it can completely occlude that pathway. So they may still have cyclic abdominal discomfort, like, hey, I'm still feeling like I have, much like I haven't bled in three months now, or several months. And that's because and the cervical ones are a little bit more rare. Right? Bleeding, common. Okay? Bleeding, common. About 50% of these patients will come with bleeding. Again, most are asymptomatic initially, depending on where the leiomyoma or the uterine fibroid is located. Okay? If it's located, we'll go back to this other picture. If it's located more posterior or more inferior, we could have problems with it having kind of a mass effect. It could affect the bladder, it could affect the rectum. These patients may come in with urinary frequency, thinking they have a UTI, it's been going on for several months, when urine is always normal, urine culture is normal. I'm having constipation. I didn't used to have constipation, but now I seem to have a lot of constipation. Then I'll be doing a rectal exam to see if you feel for any masses. Maybe they have incontinence that's associated with this as well. Sometimes they will just, especially if it's located in the myometrium, sometimes they'll just come with a pelvic pain or pelvic fullness is a primary complaint, and maybe a little bit of intermittent bleeding, or yes, my periods seem to be a little bit heavier, but nothing really significant. Infertility, with submucosal, these patients may present with not only abdominal bleeding, but that infertility is their primary presentation. Okay, diagnosis. Maybe we'll feel something on by a manual exam. I wouldn't necessarily, at least in the initial stages as you become PAs, probably rely specifically on your hands-on. Okay, but maybe you'll feel a slightly increased size of that uterus. Okay, transabdominal or transvaginal ultrasound is going to be your diagnostic tool of choice. So ultrasound. Okay, otherwise radiologic studies like CT. You may be doing a CT for something else, like they're coming with low abdominal pain, they'll do a CT for that. It's like, oh, they've got fibroids in their uterus, but it shouldn't be done to say, please perform CT evaluate for uterine fibroids. Right? That should not mean you'll get a phone call from radiology. Probably fairly quickly about that. So ultrasound is going to be your tool of choice for evaluation. And MRI, okay, possibly. If we've done our ultrasound, we don't see anything, then maybe MRI. And actually, oftentimes what helps us delineate, is this a fibroid that's in the myometrium, or is this beds of endometriostroma consistent of adenomyosis in the myometrium? So ultimately, that be done, especially if a patient is on a surgical approach. So we've tried medical management, and that's not getting better. They usually OGLA and will hold a pelvic ultrasound, so they know what they're doing if the intent is to take surgery. So medical management for a leiomyoma or uterine fibroid, if they're bleeding significantly, you've got to be really careful. Okay? So if they're coming and you're working, let's say, if you're doing ER rotation or urgent care, you're going to check an H&H on them. If they're really concerned, repeat that H&H in a couple hours and make sure it's stable. If you're coming in, they see you like, yeah, I've been having this going on for several months, check an H&H and see if they're anemic. Doesn't mean they need immediate intervention today, but hey, let's have them follow up in about 3 to 4 weeks. Repeat an H&H, monitor those H&Hs. If they're getting more and more anemic, you've got to do something about that. Okay, levonorgestrel IUD is still going to be on our plate, just like it was for adenomyosis, as one of the primary treatments for these structural abnormalities. What that does, that progesterone helps keep the lining of the uterus really thin, to help reduce, to essentially atrophy the endometrium is what we're trying to do, to reduce the amount of bleeding. The other thing it does is for those uterine fibroids, for the adenomyosis, it can reduce the size of the fibroids and reduce the amount of the size of the adenomyosis as is in the myometrium. We can use combined oral contraceptives as well. If they don't want IUD, you can use combined oral contraceptives, and that tends to work. Again, GnRH agonists can be used if nothing else works, but it should not be your initial treatment choice. Ultimately, these patients may have to have surgical intervention. They may have to have a myomectomy, which is going in there just removing the fibroid itself. Okay. It does preserve fertility by doing that, but that fibroid can come back over the next 7 months. If they have excessive bleeding, they talk about things like endometrial ablation. Endometrial ablation, essentially they come in and they ablate the entire endometrium, which is, it eliminates them from being able to have babies in the future. So that depends on what their ultimate goal is. If this is someone that's still reproductive age, they still want to have children, then that may not be an option for them at this time. They call it something called uterine artery embolization or uterine fibroid embolization. Again, preserves fertility, but they're going in there and trying to cut off the blood supply to that uterine fibroid. But there can be a lot of complications if the patient does get pregnant with it. The placenta can't implant correctly, especially if they're trying to implant where that fibroid was treated. And ultimately, definitively, not initially, hysterectomy. 35-year-old female comes in, abdominal bleeding, I'm lightheaded, I'm dizzy, we diagnose uterine fibroids, hysterectomy is not the option to be in, right? We're going to try some sort of medical management. Hysterectomy is a general surgery. It is not without risk. So don't put patients at risk when they don't need it. Don't choose that as an answer on the test. I wouldn't choose it. I will tell you when to choose it. This is not one. This is not the time. All right. So indications for surgical intervention. If they have rapid enlargement, if they have severe dysmenorrhea, if they have increasing anemia, or they have acute onset of bleeding and they're having more and more anemia. If they have any sort of compressive or obstructive signs and symptoms like constipation, like frequent urinary tract infection symptom, or if these patients come in, they're postmenopausal and they have their fibroid is growing, that would be unusual because they don't have a lot of circulating estrogen unless they're on some sort of estrogen replacement. So that would be an indication for the general surgeon or the OB/GYN surgeons to evaluate them. And then ultimately, infertility, if that's their primary complaint, then they go in and remove that uterine fibroid. Now, when we think about fibroids versus adenomyosis, remember, fibroids are going to be round, rubbery, more discrete. And adenomyosis is going to be global enlargement of that uterus. We're having those endometrial cells inside the myometrium. Right. And then we have for our structural, we have endometrial hyperplasia or malignant transformation. So proliferation, we can have endometrial hyperplasia that has with atypia and without atypia. So if we have without atypia, okay, that's going to be less likely to be concerning, less likely to transform into endometrial cancer. If we have endometrial hyperplasia with atypia, that means we have atypical endometrial cells, how much higher risk for cancer. For our perimenopausal or postmenopausal patients, and we have endometrial hyperplasia with atypia usually around 60s, mid-60s, and without atypia, we'll see that in our early 50s and 50s. So oftentimes, this is due to patients that are on estrogen or have continuous estrogen exposure without, it says unopposed estrogen, that's unopposed progesterone. And so please make that change, it's unopposed progesterone. So if we think about the mechanism of action for inovulation, in ovulation, is a continuous estrogen problem without the appropriate progesterone. These patients, if they have that, they're at higher risk for this. Oftentimes, again, abnormal uterine bleeding. Less likely will they present with, hey, I'm here for my routine cervical cytology or routine Pap exam. And on that Pap exam, when you get the results back, it'll say something like atypical glandular cells or benign endometrial cells. That means the cells from the endometrium have worked their way south, and now they're on the outside of the cervix, and we're going to see them on, or have them on our cervical cytology. So either in the cervical canal or on the outside of the cervix. For a postmenopausal patient, we may see thickened endometrial stripe on a transvaginal ultrasound. And again, depending if it's with atypia or without, it may coexist with or may ultimately progress to endometrial cancer. How do we diagnose this? A premenopausal patient, transvaginal ultrasound is not reliable. Okay? Does it mean you don't do it? Absolutely, it does not mean that. You still do it, but here's the reason why it's not reliable. You guys probably already know this, but I'm going to say it. Because as a female goes through her menstrual cycle, from the follicular phase, luteal phase, estrogen levels are going to change. Okay, very early on during the bleeding phase, estrogen and progesterone are low. After the bleeding phase, estrogen starts to increase. So if you did an ultrasound on day 5, your estrogen level is still going to be low. The endometrial stripe is going to be a different thickness than if you do an ultrasound on day 12. So it's not reliable. We're looking for a thickness of less than 4, but we may that can be completely normal thickness in a person on day 12 of menstrual versus day 5. Okay? So it's not recommended as your only guide. So if you do an ultrasound and it says endometrial stripe is thick, that doesn't mean they have cancer. When did we do the ultrasound on day what of the cycle? So ultimately, and these patients need endometrial biopsy. We need a biopsy of the cells within the endometrium. And we need to send that off for histopathology so we can see what the difference in those cells are. So, yes, transvaginal ultrasound, but don't only think, well, once I have that, I'm done. Endometrial biopsy needs to be on the list of these patients that have persistent bleeding. And unfortunately, even endometrial biopsy can sometimes miss this, because if we have it in a specific area and they don't biopsy that area, then they may not be able to, they may miss this as a diagnosis. A lot of time with that endometrial biopsy, they'll do a histoscope. So they'll actually look in the uterus as they're doing the biopsy, and they can oftentimes see some abnormal patterns in those biopsy in those areas. So if they do that biopsy and it's normal, but they still have on their differential, like I'm not convinced that this person doesn't have endometrial hyperplasia, then a DNC. So they'll go in those scraped areas of the uterus and they'll send that off for histopathology. In postmenopausal patient, we're going to do transabdominal transvaginal ultrasound, and we're going to look at that endometrial stripe. Okay? If it's equal to or less than 4 millimeters, according to the American College of Gynecology, it's pretty low risk that this is anything that's concerning. If it's greater than 4 millimeters, then it's more concerning that this person has endometrial hyperplasia, and these patients ultimately are going to need an endometrial biopsy. So ultrasound is still going to be your initial, and then endometrial biopsy. If someone has endometrial hyperplasia without atypia, meaning this, they've had their ultrasound, they've had their biopsy, results are back. Right? The results of the biopsy are back, and the results say this is endometrial hyperplasia without atypia. Okay? In a good portion of these patients, it will just kind of go away on its own, spontaneously regress. Very low risk for cancer progression, 1 to 3% over the next really 5 to 10 years. Very low risk. Okay? Ultimately, they're typically going to put these patients on some sort of treatment. Hormonal therapy gets pretty good response. In premenopausal patients, we usually do 3 to 6 months of a low dose progesterone. oftentimes in the form of that levonorgestrel IUD, because that levonorgestrel IUD gives us constant secretion of that progesterone. Okay? And by doing that, we can reduce or kind of atrophy the endometrial lining and reduce the amount of the cells that we have. So levonorgestrel IUD we can use, and then the recommendation is a repeat biopsy at 3 to 6 months. Okay? If you have 2 negative biopsies, so we're placed on that levonorgestrel IUD is in place, and you can do the biopsy, you don't have to remove the IUD, they can do the biopsy with the IUD in place. Okay? If you have 3 months, have a negative, nope, we don't see all the hyperplasia anymore. They repeat the biopsy again in 3 to 6 months. If we have 2 negatives, okay, then the decision point is they usually keep them on the progesterone, and then they switch to once a year. Okay? So we got to have negatives before they can change it from that 3 to 6 months. Ultimately, if the hyperplasia resolves with the progesterone, and they typically will keep it in place. If it does not resolve, then they have the option of changing the progesterone. Okay, so there's only 1 dose of IUD progesterone, but they can put them on an oral progesterone that has a higher dose of progesterone, or they could potentially offer these patients a hysterectomy if childbearing is complete. For postmenopausal patients, okay, they can still do the same thing. They can offer them the progesterone only, the IUD. Okay, still going to be repeat biopsy at 3 to 6 months. You have 2 negatives before they can go to a year. Okay, or hysterectomy. And if they're postmenopausal, if their childbearing is complete, they may push them more towards a hysterectomy. Okay. Guidelines changed about 2 years ago because of the efficacy they have seen with the levonorgestrel IUD to say, you know, yes, we still kind of we'd like them to have this hysterectomy, but we all have seen really good results with the progesterone only, and so we're more apt to say that's fine. Well, previously it was a big argument, like, no, you need a hysterectomy for postmenopausal. Now it's like, if you really don't want a hysterectomy, then we can treat you with progesterone. If they have endometrial hyperplasia with atypia, meaning again, ultrasound is done, biopsy is back, biopsy says this is atypia, so we've got atypical cells present, okay? This is a much higher risk of them developing endometrial cancer. So we want to make sure we prevent that progression to endometrial cancer. So in premenopausal women, okay, if childbearing is complete, we're going to do a hysterectomy with salpingectomy, meaning uterus, fallopian tubes are going to come out, and plus or minus the oophorectomy, which is the ovaries. Salpingectomy is your fallopian tube, oophorectomy is going to be your ovaries. If they are not done with childbearing, then we talk about progestins. Use again the levonorgestrel IUD, and with that repeat endometrial biopsy every 3 to 6 months, okay, until childbearing is complete. And use again the levonorgestrel IUD. They can give oral progesterone if that is needed. Postmenopausal women, they're going to recommend a hysterectomy with BSO. So BSO, bilateral salpingo oophorectomy. So uterus, fallopian tubes, and ovaries. Because if you don't take the fallopian tubes and ovaries out, there's still risk for cancer to develop in those from the endometrial hyperplasia. Even though you remove the uterus, those cells unfortunately still hang out. And so they want to reduce the risk of having any reproductive cancer, so they take that. Okay. If someone cannot undergo a hysterectomy or they're unwilling, then we've got the progesterone therapy, or the oral or levonorgestrel IUD. This is a transvaginal ultrasound, and it's looking here in the middle. This is the endometrial stripe. Okay, this is a postmenopausal person. Normally we think of something we should see it less than 4 millimeters. So this is much thicker than that 4 millimeters. This is what they're looking for on that ultrasound. So again, when you're ordering the ultrasound, make sure you identify if the patient is premenopausal or postmenopausal on your ultrasound order, so that way the radiologist can kind of give their differential when you're reading or giving you the result. The other thing is, if you have the information, and you should, is what day of the menstrual cycle are we on? I will put that in my order as well, if they're premenstrual. Okay. You will most likely not be doing an endometrial biopsy, but when you talk to your patients, you say, I'm gonna refer you for an endometrial biopsy. Don't think they're not gonna say, wait a minute, what is that? What does that mean? What are they doing? Because they're gonna do it, right? So really what this is they'll take anybody here an operating room technician? They'll take this little claw, for lack of a better word, and they'll hold on to the cervix to stabilize the cervix, and then they'll take a pipette and they'll put it up through the external os to the internal os into the endometrium, and the end of this will come out, and it has little grabbers on it. They're conscious. None. They just do it. Yes, it is actually surprisingly pretty well tolerated. I mean, it's super uncomfortable, but it's pretty well tolerated. Most women are like, well, I don't want to do that many more times, but it wasn't as bad as like giving birth, I suppose, right? It's pretty well tolerated. Usually, no. Now, there are some that if they really can't tolerate it, they can actually take them to the operating room. Like my sister had to have this done, she couldn't tolerate it because her cervix was so stenotic. They ultimately took her to the operating room and they did the biopsy under a scope. Okay? So but most of the time, they will give them, if they need it, they'll give them a little bit of something like a misoprostol to dilate the cervix a little bit. So it's a pill that goes up by the cervix, and then it'll dilate it, so it makes the procedure a lot more tolerable. But usually, no significant complaints. So they go in, it has a little arm that comes out, and then it does biopsy and stuff. So you still have that look, you're like, yeah. It is. I've seen lots of these done, and most women are just like, oh gosh. Okay, and they're like, okay, I'm done. Because it doesn't take very long to do it, so unless they need to take them to the operating room, they won't. Right. We have, that was our non-structural causes, right? Our structural causes, sorry. That's the end of our structural causes. Let's go into our non-structural causes, and we're going to use that mnemonic coin for our non-structural causes. Coagulopathy. Okay, so coagulopathy, upwards of 20% of patients, 13% of those having some sort of variant of von Willebrand's disease that has been undiagnosed. Up to 20% can have some other undiagnosed coagulation disorder. So most of the time we're going to see this in a little bit younger population for this abnormal bleeding. Systemic diseases like leukemia, about liver failure can cause this. Medications, if someone's on an anticoagulant because they had a DVT or PE, that certainly can cause increase in vaginal bleeding. Chemotherapeutic agents can also cause abnormal uterine bleeding. So you want to think about those if someone's coming in. But the questions to help you determine if we think this is a coagulation problem are over here to the left. So ask them about, have you had prior pregnancies? Did you have any problem with postpartum hemorrhage? Any surgery-related bleeding? What about when you get your teeth cleaned? You seem to have a lot of bleeding in your gums after teeth cleaning. Brushing your teeth. When you brush your teeth, you have bleeding on your gum. That's not really unusual, right? Excessive bruising for these patients. I ask them about that. Do they have frequent bloody noses? What about any family history of any sort of coagulation disorder? So you want to, most of the time, this will not be the case. So if you have any of those questions that you're like, that's a little bit unusual, then we're going to add labs. We're going to add coag. We're going to maybe add von Willebrand's fracture or fibrinogen level. Otherwise, we don't often do those type of labs for patients that just have fibrinogen. Coags, I will often do PT and IMR, I often do, but I don't do von Willebrand's or factor VIII unless they have some family history or they're answering some of these questions, yes. If they have that, we got to figure out the underlying disorder, we have to treat that, and then ultimately that should improve that. Okay, ABO, AUBO, ovulatory or anovulatory dysfunction. Okay? Pretty common, especially at those extremes of age when the HPO axis is not completely mature. We think about ovulation, we have prolonged progesterone secretion. Think about anovulation, these patients are not going into that luteal phase. We have that increase in estrogen, but not quite enough to push them over for that LH surge and into ovulation. So we have multiple anovulatory cycles, oftentimes mixed with ovulation, but they're going to have that irregular cycles because of that estrogen withdrawal that doesn't occur at the same time every single month. Most times these patients, again, diagnosis of exclusion, when we think about anovulation, let's figure out why are they not ovulating correctly. Not only do we see that at the extremes of age, we see the person that's lactating because they're going to oftentimes, as they're going back to the regular ovulation, like intermixed anovulatory cycles, so that 3 to 4 to 6 months postpartum period. Certainly, if they're pregnant, so can you be pregnant and have bleeding throughout your entire pregnancy? You can. Okay? It's unusual. It's certainly not unusual at all to have first trimester bleeding, but there are some patients that continue to bleed throughout their entire pregnancy. Certainly, again, one of the diagnoses is to figure out to make sure there's no other reason for them to have it. Make sure they don't have an infection or something. Okay. Hypothalamic dysfunction. So we think about the whole HPO axis. We start from the top. Is there something going on with the hypothalamus? What about the pituitary? What about going on with the ovaries that potentially cause this? Have they had extreme weight loss or extreme weight gain? Because that can cause abnormal bleeding. And then our last part of this, EIN, or endometrial causes. We have endometrial atrophy as someone's going more towards menopause. Does someone have endometriosis, which is inflammation of the endometrial lining that's causing it? Iatrogenic. Did they just have an IUD placed? Or some sort of oral contraceptives or combined hormonal contraceptives that can cause it? Medications, infection is what we call under not otherwise specified, which would be our AUBN. So AUB malformation, less than 0.1% of patients will have that. So oftentimes I wouldn't have that on my primary differential. I have a lot of other things on there. If they're coming in with excessive bleeding, that would be the one thing we should think about. We think about the mechanism for anovulatory bleeding. Anovulatory bleeding. Estrogen release that stimulates an LH surge for anovulation. Do we even have an LH surge if we have anovulation? No. Continuous estrogen stimulating endometrium? Yeah, that's the problem, right? Estrogen is kicked out, but not high enough to push these patients on ovulation. So no progression to the follicular phase. No, we're stuck. Like 51st dates in the follicular phase. Corpus luteum, no, because that's going to happen in the luteal phase. And progesterone, that's the luteal phase and stuff. So continuous estrogen stimulation. What do we do? So these patients come in, first of all, and I know this is kind of a weird thing, they got to confirm the bleeding is coming from the uterus. When patients come in, do you think that they say, I'm having abnormal bleeding? No. They say, I'm having vaginal bleeding. They don't know where it's coming from. They just know that it's coming from the vagina. So we've got to confirm, hey, is this in fact a UTI that they're having? They're bleeding from there. Is there some sort of lesion in the vagina? Do they have an infection? Let's confirm where the bleeding is coming from. That usually means you're going to need to do a speculum exam and look at the cervix. Do I have bleeding that's coming from the cervix? Let's look at the size of the vagina. Do I have any lesions there? Do I have bleeding? Where exactly is the bleeding? So let's confirm it's coming from the uterus. Okay, that's going to be part of that. Is going to be our history. We're going to get our physical exam on these patients as well. And with their history, try to identify any family history of anything. Have they recently been on any medications? Recently come off any medication? They have excess of hair growth that's been occurring. And then we've got to get our labs. There is a lab component typically to this. HCG, CBC, maybe a thyroid. I give TSHs all the time on patients, Even in the emergency department, when they have kind of a more severe kind of complaints. Coagulation studies associated with this. And then maybe prolactin if they have, headaches that you can't really figure out why they're having headaches, there's a new onset, some minor vision changes, something that might indicate that they have something going on in private. If you're at risk for STI, consider doing that STI testing. What about a cervical cytology? And maybe they haven't had a cervical cytology or FEB exam in several years. Maybe that's the cause, and that's what's causing the bleeding. So we can potentially do that. And then a radiologic study of choice is going to be that pelvic or that transabdominal ultrasound. Okay. Ultimately, something like a saline infusion scan or a hysterography may be needed, but usually that's going to be done by our consultant. It's typically not something that we're doing. I think I've ordered a saline infusion scan maybe a half a dozen times in my 10 years as primary care. So it's not something that we're doing very often. Usually we try medications on these patients when we get their ultrasound back. If it's not working, then we refer them and do those additional studies. Okay. For patients that are over the age of 45, or if they're younger than them, they have risk factors of unopposed estrogen, okay, postmenopausal, they failed medical management. Those patients need to be referred. You can't hold on for a year. You're typically not getting endometrial biopsies, and usually they're going to need to be having an endometrial biopsy. So if they come in, they're premenopausal, we're going to grab those labs. If any of those labs are abnormal, TSH, prolactin, pregnancy, we're going to address that. Okay? Otherwise, let's do a transvaginal ultrasound in these folks. Let's look for those structural abnormalities. If they have an abnormal endometrial thickness, okay, that may be concerning depending on what else the radiologist is reporting. They may say that it's thickened and it looks abnormal. Well, if that's the case, then send them for a biopsy then. If they have risk factors and they have a thickened endometrial stripe, then I would recommend sending them for a biopsy. If they have a normal appearing endometrial stripe or endometrial thickness, then go back to your medication management, which is typically going to be a levonorgestrel IUD or a combined oral contraceptive for these patients. Once we get beyond the endometrial biopsy, that's our consultants. Don't look beyond there. That's when our consultants are going to have to use our patients. And then once they get them under control, they oftentimes will send them back to you. And then you have to just do medical management after that. If they're postmenopausal, really important is to look at that endometrial structure, endometrial thickness. Less than equal to 4 millimeters, and they don't have any risk factors, which we can observe and we can watch them and still try to with medical management with progesterone. If it's greater than 4 millimeters, those patients need an endometrial biopsy. I try to tell patients or students, well, you can remember that as a sign or a commercial, call the fours, Jeff Davis. I say you're going to be calling the fours if you don't pay attention to greater than 4 endometrial thickness. And you call him because he's a lawyer, you're going to need his help to get you out of that mess. Right? So greater than 4, or if they're less than 4, and they have risk factors. My mama had endometrial cancer, my grandma had endometrial cancer, everybody's got endometrial cancer. Or they've been on unopposed estrogen for some reason, those patients need an endometrial biopsy. So your treatment is going to be based on if it's a structural abnormality, if it's a non-structural abnormality, structural hormonal therapy. Okay? Ultimately, maybe surgery. If non-structural, you've got to figure out the cause, and then you're going to address that cause specifically. If someone comes in, you've got to determine is this an acute problem or is this a chronic problem? Okay? Acute, we can say it's acute and stable or acute and unstable. So they come in and they're hypotense, they're tachycardic, they feel like they're going to pass out every time they stand up. That's concerning. That's typically we consider that unstable. If they come in and no, I just feel a little bit dizzy, otherwise I'm fine, vital signs look fine, we can call that acute, but they're stable. They require different interventions. Chronic is going to be that, I've been bleeding like this for 6 months. Oftentimes on labs, you will see an anemia, but it's a chronic anemia. Hangs out between 9 and 10 and 11. It's been there for a while. This is usually not something new. Okay? So in a acute bleeding, these patients could say, I've had this constant, this intermittent bleeding for several months, but yesterday, today, I'm changing a sanitary product every hour. So this is acute on chronic. For those patients, if they're stable, we've got a couple of different options. We can do an oral progestin. We can add tranexamic acid, gram to 2 grams for these patients orally. Okay, we could do combined oral contraceptives, but not just one. They're going to do one every 6 hours, 6 to 8 hours for a week, and that will help reduce the amount of bleeding they're having in this acute phase. Okay? If they're unstable, or you tried those oral medications and they did not work, now these patients oftentimes will have to go to the operating room. They'll have to go in and scrape the lining of the uterus with a DNC. Okay? Sometimes they'll have to use something like a balloon tapenade, which is essentially a big Foley, and they're pushing against the lining of the uterus to cut off the blood supply or tamponade that blood supply. They might have to go in and do an embolization, especially if it's coming from a fibroid. And then ultimately, if they've tried all that in their surgical approach and none of that works, before these patients even go to surgery, they will have to sign that they agree that a hysterectomy. They don't have to sign, but they will say, look, ultimately this may end up in a hysterectomy if we cannot control this bleeding. Okay? There's IV medications that we can give these patients that are having this acute bleeding. Okay? IV Premarin is one of the most common things we give, so that's a type of estrogen that we give. We can give depo-hydroxyprogesterone acetate as an injection as well. We can give TXA. We can give oral medications, oral progesterones as well. So I wouldn't memorize this slide. Just know there's different approaches for acute and chronic treatment for these patients. So if it's chronic and it's been recurrent, we think about endometrial suppression. Okay? That reduces the amount of proliferation that we have at the endometrium. The bone adjuster IUD is typically considered our first line treatment. Okay? We can do progesterone-only contraceptives as well. We can do extended cycles, okay, or the transvaginal ring. They can do depo-hydroxyprogesterone acetate, which is Depo-Provera as well. But remember, with any of these, there is a potential for increase in bleeding for those first several weeks. We've got to educate our patients about that. I'm sorry, but this may make you a little bit worse before it makes you better. Okay? And then anti-inflammatories, NSAIDs. A high dose NSAIDs, 800 milligrams of ibuprofen 3 times a day, naproxen 500 twice a day. If they're not already on them, so they'll get the benefit. And that just normalizes the prostaglandins. If we reduce the amount of prostaglandins that are circulating in the endometrium, then we're going to reduce the amount of bleeding that these patients have. And oftentimes you want to add those NSAIDs to your other treatments. I don't typically do the NSAIDs by themselves. I add it to, but you can do NSAIDs by themselves, but use this in addition to. We want to talk about coordinating endometrial sloughing, meaning giving the endometrium a rest. And we can do that by giving them the hydroxyprogesterone acetate, 10 milligrams a day, usually for a 10-day cycle. We want to do the work for the endometrium. Let's take it out of the endometrial pain, and we're going to allow the endometrium to rest. And then after that 10 days, we're going to reset the endometrium. Antifibrinolytic therapy, that's that TXA. Okay? 650 to 1,300 milligrams we can give these patients. And if they're bleeding just at certain times of the month, we can actually prescribe them to take TXA during that time period of the menstrual cycle. All right, we got to stop. We'll finish up these last couple of slides next time we meet and then go on.